Everyone, welcome. Welcome to the University of Michigan Concussion Center Speaker Series. My name is Doug Wiebe. I'm a professor of epidemiology, and I'm on the Concussion Center Executive Committee. I'm excited that you're able to join today. Over the years at the Concussion Center, we've been fortunate to know and work with some of the world's leading experts and researchers. The goal of our series is to bring those speakers to you and create a space where you can hear and learn from those who are challenging what we know about concussion and create and implement new knowledge into your daily lives. A few housekeeping items before we introduce the speaker today. The session is being recorded. It will be available on our website, concussion.umich.edu, in a few days. There will be some time for discussion at the end of the presentation. Feel free to enter your questions into the chat. This session is approved for CME and board certification category A credit. You will receive an email at the end of the session with information you'll need to claim the credit. So without further ado, everyone, I wish you a warm welcome and a special thanks to our guest speaker, who I'm happy to introduce. Dr. Ruben Echemendia is the clinical director of the Concussion Care Clinic at the University Orthopedic Center in State College, Pennsylvania, which is a multidisciplinary concussion evaluation and management program. Dr. Echemendia has extensive clinical and research experience with sport-related concussions, and he's spoken internationally on issues related to traumatic brain injury in sports. He's currently in independent practice after having spent 8 years on the clinical psychology faculty at Penn State University, where he was director of the psychology clinic. Today, Dr. Echemendia will present the process and science underlining the new SCAT6 tools. The SCAT6 is a standardized tool for evaluating a suspected sport concussion and can be used on individuals age 13 and older. The adult SCAT6 is designed for use by medical professionals. For those of you who are not familiar with SCAT6, this tool includes a summary score, including a memory assessment, Glasgow Coma Scale examination, cervical spine assessment, symptom evaluation, cognitive screening, neurologic screening, balance examination, and delayed recall. We're delighted to have you and look forward to hearing from you. Welcome.
Thank you. Good afternoon, good morning in some areas, and thanks so much for everyone for being here. In particular, thanks to Dr. Broglio and the University of Michigan Concussion Center and the hospitality they've shown me and for the invitation to be here today. Just a note about what we will be talking about today. We will be talking about the process, the scientific process that underlies the development of the SCAT6. We will also be talking about some aspects of what the SCAT6 will contain. Unfortunately, due to timing related to COVID, everything has been delayed a bit with respect to the publication of the consensus document or the conference documents that arose out of the meeting of Amsterdam. And currently, all of the materials are embargoed until they are published. So I'm limited in what I'm able to share with you today, but I can guarantee you that come June, all of the information will be published and available to you, and you can then refer back to this discussion. And also the recording that comes from this meeting will not be available until after the materials are no longer embargoed so that we can share the information freely. So with no further ado, let's move forward and talk about why the clicker doesn't work. Somebody want to advance that, please? It always happens. All right. Okay, now we got it. So a bit of history with regard to the concussion statements and to the concussion support group and the progress that we've made over the years. This all started back in 2001 in Vienna. And the idea there was that we had very little knowledge of concussion at the time. We knew it was something that we needed to deal with. We knew that it was something that was important, but we quite didn't know how to do it. So it became like the wild, wild west out there. Everybody was doing their own thing. Nobody really knew what worked or what didn't work. And everybody was kind of flying by the seat of their pants. So a bunch of experts got together and said, you know, we need to do something about this. We need to do something about educating the public, and particularly the health professionals, in terms of what this injury is, what's the best way to recognize it, and then what's the best way to manage it. So like everything else that was happening at the time we also had grading scales that were being developed, so you can grade the concussions from grade 1, grade 2 to grade 3. If you had a grade 2, it meant this in return to play. If you had a grade 3, it meant this for return to play. We're trying to pull everything together into a cohesive document that could be useful for clinicians. So that's how it all came about. Everybody, the meetings got together and started to discuss a variety of issues ranging from prevention to detection, identification, management, assessment, and moving forward in terms into later stage. And that was all by consensus. It was all by expert consensus. Everybody saying, well, this is what I do. What do you do? What do we do? And trying to come up with the best approach to give advice to these clinicians who were working with the patients. That then developed into the first consensus statement meeting, which really took off at the time. It was very well welcomed by the medical community and the public at large as a way of pulling things together. That then morphed 4 years later into Prague. Prague followed a very similar model in terms of wanting to come up with tools, ideas, and guidelines that were useful to the clinician, not just the researcher, but useful to the clinician in terms of being able to provide clinical care to these patients, these athletes who were experiencing difficulties with concussion. And initially, the sports that were involved were ice hockey, rugby, football, soccer, if you're from across the pond, as well as other statements. And you'll notice that it says that it was a summary and agreement statement. It was never intended to be a practice guideline. It was not intended to be a standard of care at that point in time. Because keep in mind that although these meetings referred to the literature, they didn't involve a systematic evaluation of the literature in order to condense that into the best scientific approach. Because quite frankly, there wasn't much out there at that point in time. There wasn't much in the literature to really try to pull together, at least from an empirical standpoint. There were a lot of opinion pieces, there were a lot of opinions about what to do, but we had very little in the way of empirical data to guide what we were doing. Then we moved forward to Zurich in 2008, and that was the first formal consensus meeting. And it was a consensus meeting that followed the guidelines set forth by the National Institutes of Health and the Consensus Development Conference format. That now systematized everything that we were doing. It put everything that we were doing into a structure that had been developed by other individuals. So it wasn't just, let's sit down and talk about it. Let's sit down and talk about it in a particular way, using a particular format so that we can then put forth to the public something that had some more meat to it than before. It wasn't that what happened before was bad. It was just that it's all we had at that point in time when we start to progress as the years went on. Then we went on to the 2008, 2012, and they make fun of me because my hair was a lot darker back then. It just shows the ravages of aging as we go along. But nonetheless, once we got to 2008, 2012, now we started moving into the highest scientific standards that we can incorporate at the time as put forth by national bodies, convention, conference proceedings, and things of the like that were standard at that time for scientific information. We wanted a very structured format that had transparency with clinical applicable outcome. And I keep coming back to that because even though the basis for all of this is research, the goal is a clinical application of that research. So it's a true approach towards translational knowledge and getting the information out there to folks. Then it got bigger. It got a whole lot bigger by the time that we got to Berlin. And now we start talking about very, very systematic meetings. We started talking about very detailed and codified approaches to selecting the literature, canvassing the literature, pulling the literature, determining the quality of the literature, and so on and so forth, so that we can do it in a very concise, transparent, and formal way. So now let's fast forward to Amsterdam, and I'm going to walk you through the process because many people don't understand what goes on behind the scenes in one of these conferences. And really, that's what's important, because what goes on behind the scene is what drives the ultimate outcome in the scientific information and translation. So we started planning this meeting back in 2018, August 2018, right after the last consensus. Then you jump into the new consensus in terms of how we're going to move forward with that. At that point, we got in October of 2018, then the scientific committee was appointed and developed. And it's the role of the scientific committee to then guide the scientific process to help identify what the scientific content is going to be and where we're going to end up going at the end. So they kind of set up the roadmap for us. On the left, you see the organizing committee. These are all of the organizations that sponsored the meeting. So basically, they funded the meeting. They provided the funds that allowed the meeting to go on. And we're very grateful to them for that opportunity. Then we have the scientific committee on the right-hand side. Catherine Schneider and John Patricius served as co-chairs of the scientific committee, and they did a terrific job trying to herd cats, because all of this is a process of herding cats when you get that many experts in the room at any given time. The scientific committee, if you look at it and recognize the name, it's multidisciplinary, it is geographically diverse, and culturally diverse. We can get a lot better at that, but it is what it is at this point in time. So the scientific committee then got together and we decided, all right, let's look at the past reviews, let's look at the current literature, and what are the questions we want to ask at this point in time? What do we want to know? What is it that we need to incorporate into this? So we included some new questions that hadn't been asked in the past, and that we hoped we would find some research to be able to fully address these new areas. So we'll talk about what they were. And then the scientific committee identifies the expert panel. So the expert panel is the group of experts across the world that are being brought together to address these issues. All of these experts, again, are multidisciplinary. Some are not even in the concussion space. We had outsiders coming in to make sure that we weren't just engaging in confirmation bias and spinning our own wheels, that we had other individuals who were contributing to the process and to keep us in the straight and narrow. And to that point, for the first time, we had an ethicist who was appointed to the scientific committee so that we can really look at it from that perspective, which really, as a member of the scientific committee, brought me a new understanding of how to approach many of the things that we do in medicine and take for granted and don't often think about from an ethical standpoint. And it also taught us how to write. It's a very interesting process. We then began the systematic reviews. And what do the systematic reviews do? They ensure that the literature is searched systematically. So if you've ever been involved in one of these, we put in what the inclusion criteria are, and that is what gets you in, and what the exclusion criteria are, and that is what blocks you from getting in. And the inclusion-exclusion criteria varied by question that was being asked or by systematic review. Because if you stop to think about it, and we were talking about this the other night at dinner, is that if you use the same template for everybody, then it really doesn't help in those areas where the research is not as fully developed, where you're still in the hypothesis generation phase, as opposed to the hypothesis testing phase. So the reviews differed based on the questions that were being asked by the review. So if the review, for example, is asking a question that has to do with predictive utility or positive predictive value, or the extent to which it is prognostic of a particular issue, it has to be able to test those hypotheses. It has to have the methodology and the rigor to be able to go there, as opposed to a basic case control series where you're using that to investigate and ask questions about things that we really don't know about to then help formulate what happens in a more formal systematic review. Does that make sense? Okay. Standardized guidelines based on the British Journal of Sports Medicine, the author instruction, the PRISMA guidelines, which I'll show you in a minute. A process document that was developed a priori and reviewed by the scientific committee, the lead authors, the methods authors, and the systematic review editors, all saying, this is what we're going to do. This is what it's going to look like when we start this process. So we knew what it was in advance, and that really gave us guardrails, because when you're dealing with this many people, if you don't have the guardrails, it's very easy to go off into the wild blue yonder unintentionally. The focus for this was on sports-related concussion. And that's important, and it has implications. It's important because we didn't use community samples of athletes. We only used sport-related concussions. So the community samples were not included as part of this because concussions in those samples differ from the sport-related concussions. For example, mild traumatic brain injury due to a motor vehicle accident introduces a variety of different variables, not the least of which is possible litigation effects that come into play that you need to tease out. Also, typically, the population for sports-related concussion is younger than the population for concussions in the general population. So we wanted to be responsive to that niche, to that specific group. But there are drawbacks to that as well. And the drawbacks become apparent in the pediatric population. The reason for that is that most pediatric programs don't have health professionals at the ready and aren't organized to be able to collect the data or to provide the care. So they typically show up in the ER or they show up in the pediatrician's office, none of which are picked up by this kind of review. So you need to know what the limitations are about some of these reviews and some of the decisions that you have to make in advance, and things that we will likely change moving forward in order to improve that, because we had a very low yield in terms of pediatric population samples that we needed in order to be able to make recommendations with respect to the child SCAT6, which I'm not going to go into in great detail unless you guys ask questions and are interested in that. Okay, so what are the systematic reviews? There's risk reduction, which is prevention, recognize, acute screening, which is the one that I headed up, and then, reevaluate, which is an office assessment, rest and exercise, rehabilitation, reconsider, which involves persisting symptoms, recovery, return to school and sport, residual effects, and retired. The extent to which there are high quality data in each of these questions varies across the board, and we'll talk about that in a little bit. The retire was brand new to the questions that were being asked that had not been addressed before. The others have generally been assessed to a greater or lesser degree. We wanted to ensure the literature was searched systematically, methodological rigor. We showed this already. Okay. So residual effects was the one that people want to really read about, okay? Because this is the one that includes the current controversies with respect to neurodegenerative disorders and possible CTE. So stay tuned. Come June, you'll be able to read about what's going on there. Then the one I'm going to be talking about is the acute screening, the one that I said earlier I headed up. Okay, so here we go. Any questions in-house until now? Okay. So ours was a complicated systematic review that had 6 overlapping domains of functioning. Those domains were cognition, child and pediatric. Oh, this doesn't even show up on there, huh? balance assessment and postural stability, ocular, motor, cervical, and vestibular, emerging technologies, and neurological examination, each of which had a team leader who was responsible for doing everything I asked them to do because I was heading up the shop, and then who yelled at me for all the things that we had to do. Here are all the co-authors in alphabetical order, each of which really contributed to it. This guy, not so much, but the rest really worked pretty hard at it. As you can see, it's a lot of people. It's a lot of people from a variety of different settings, and some of the names which you might recognize as being involved in this area for long periods of time. So it was a pretty significant undertaking. We wanted to review and evaluate the literature related to the identification and the evaluation of sport concussion. How do we identify it? How do we see it? And once we do, how do we evaluate it? Once we think that there's something there. Okay, this is important. Systematic, you have to have an endpoint, right? To a systematic review, or else it's going to cover 100,000 articles. So we chose 7 days as the cut point, because a lot of the literature had suggested that 7 days would be a good cut point for acute. And some suggested that even a shorter period of time is better off for acute. And we'll be discussing that as well. So the systematic review was based on any study involving sports-related concussion with children, adolescents, and adults within that time window. If it's outside that time window, different story. The goal was to use this information then to use the science to improve recommendations or to provide recommendations for improving the SCAT tools. 6 overlapping content areas, which I talked about previously, so we don't need to get into again. Here's the fun slide, okay? This is the Prisma slide. This shows you what we did. And basically, we started off with 12,192 articles that were identified in the review. Then we went through a series of different screening steps, exclusion steps. You know, does this fit? Does this not fit? Is this what we're looking for? Is this not what we're looking for? And then in the end, we ended up with 627 articles, which by systematic review standards is absolutely crazy. It is huge beyond being huge. That then was whittled down to 423. This was actually a bifurcated review. So we had 423 articles that specifically dealt with sports-related concussion. We had another 200 or so that we included because they were primarily normative studies. So we wanted, since we were doing this anyway, to coalesce all of the normative data so that we can then put together a normative manual for the SCAT tools, which hopefully is available in another 6 months or so. In the past, the SCAT tools had not been published with any accompanying normative data. And clinicians can use this and would benefit from this. All right, so when you look at the study characteristics, most of our studies were diagnostic accuracy, prospective cohort, and retrospective cohort. So not bad from a methodological standpoint. Only a few involved case control and case series, and those were more related to the normative data. Age of participants really varied, but look at here. This is what I was talking about in the pediatric group. In the 5 to 12-year-old, we had one study that dealt with that age group. And in part, that has to do with the decisions that were made in terms of exclusion criteria for the review. We had fair representation in terms of domains. Cognition took the lead, followed by balance and postural assessment and emerging technologies. If we look over here, I can't see it. Location of countries, not very geographically representative. The overwhelming majority of studies were from North America and primarily from the United States. So that becomes an issue. Year of publication is scattered. Percent female, we're averaging 24.2. So we got a long way to go in terms of understanding the female athlete and what the female athlete is experiencing in the context of concussion. But at least now we're collecting data and knowing how far behind the 8 ball we are, where in the past, we have not been doing that. If you take a look at the risk of bias, and risk of bias is the quality level of the studies, which is important in systematic reviews because you want to give more emphasis to the high quality studies and virtually no emphasis to the studies that are very low quality or high risk of bias. So you can see that in the overall total, 21% were deemed inadmissible. So even though they met inclusion criteria, the methodology of the study was such that it was inadmissible because it didn't meet the methodological rigor that we expected, and hence they were included, but not included. In other words, they were pulled, they were evaluated, but they didn't become part of the systematic review at the end. And then 70% were acceptable and 8.5% were high quality. So we have to ways to go in terms of improving the quality. And when the paper comes out, you'll see to what extent all of the different groups had higher or lesser quality. Each varied depending on the populations and the studies it came to. So what happened when we got down to the meetings? Day one, and this moves at a clip. For those of you who were there, know that this is a very fast moving target presenting tons of information in very short order. Presentation of abstracts. So there was a call for abstracts. I think 600 or so were there. And of those 600, each domain chose 2 to be presented from the podium. 2 of those were presented from the podium. And that was also a way of getting beyond the systematic review, right? Because abstracts wouldn't have made the systematic reviews, but they do represent what's coming down the pike, what we're seeing down the road. So it's important for us to have that in view and to use that also in the development of the consensus statement and the final systematic review documents. Open discussion. For the first time, we had the athlete's voice represented, which was terrific. It was having athletes who had experienced concussions, families of athletes who had experienced concussions, both in traditional athletes and Paralympic athletes and para-athletes. So that was really an important thing because that's often a population that we're not paying much attention to, and we need to do a better job at that. It was terrific working with the para athletes and their group, and they will continue working with us moving forward. And more importantly, in the further modification of the tools in order to make them more responsive to the needs of para athletes. Second day basically copied the first day, and then we threw everybody out, put all the experts into a room and ran like hell. No, we threw all the experts into the room and you saw the mishmash, you saw the opinions coming out, the discussions coming forth, and that's what's important, right? Because it's how we synthesize all of this information with all of the different viewpoints that are represented in order to come up with a final document. The expert panel then voted on recommendations from the systematic reviews, coupled with what we saw with the abstracts, the athlete voice, and the discussions in-house, ended up with the components that ended up in the final consensus statement. The tools day was the 4th day. So now we're even smaller. It's a smaller group whose job was to synthesize everything into the development of the actual tools. Okay. So again, this is where I'm limited in what I can talk about, and I would appreciate that. And I appreciate for those of you at home that you do not take pictures of these next few slides because they are still under development. Don't need to go there. So we talked about our scientific and transparent approach. We wanted a simple and clear message. We wanted continuity with the prior tools. It didn't make a whole lot of sense to come up with a SCAT6 that had no relationship to the SCAT5 that you've been using for 20 years. We wanted the avoidance of additional equipment. Most people fail to realize, or they don't think about, the fact that these tools are being used all over the world by individuals with differing levels of resources in order to be able to carry these out and different levels of training within the disciplines. So we didn't want to have any added equipment to the SCAT5. So you couldn't walk around with, an instrumented mouth guard, or you couldn't walk around with instrumented balance assessments. So it had to be stuff that were clinically available. The tools we published in a freely available format, both electronically and paper. We wanted better knowledge translation and overall to improve the care of athletes at all levels of play. So these are the outputs. You know about the SCAT6. SCAT6 is the adult version of the SCAT, which is intended for use by health professionals only. The child SCAT6 is for children 12 and younger, and that mirrors the SCAT6, but it is also only for healthcare providers. The concussion recognition tool 6 is a public-facing tool that is designed to help non-medical professionals who are out in the recreational or community sphere recognize and remove. So recognize when an injury may have occurred and to remove that player when they think an injury has occurred and get them medically evaluated. It is not for them to evaluate. It doesn't have any diagnostic kinds of questions. What it does is it has a lot of red flags. It's like, this is what you need to look for. And if you find this, this is what you should do. And then there's the SCOPE, which you probably don't know anything about. And everybody wonders what that is. And I'm going to get to that towards the end. It helps to get some more background before I get there. All right. So these are the key findings that are in many ways consistent with the last consensus statement. So I'm comfortable sharing them. Consistent with the last systematic review, the SCAT can reliably distinguish between concussed and non-concussed athletes within 72 hours of injury. Beyond that, the diagnostic utility begins to diminish and diminishes rapidly until you get to the 6-day point. So what does that mean? That means that this is not a return to play tool. The SCAT6 is not designed to be used in return to play. It is used to be designed in standardizing a clinical evaluation during the acute phase of injury. And it's important to underscore that. We removed the read aloud symptom instructions because they weren't doing much. We knew from the last systematic review that the 5-word list had a significant ceiling effect. We introduced the 10-word list last time. The literature shows that that 10-word list approximates a normal curve very, very well. So the 10-word list is the only option with respect to the SCAT. The concentration subtest also revealed ceilings or evidence of ceiling effects. And we discussed about how to increase complexity. And we did so in the months in reverse, not the mons in reverse. The neuroscreen was revamped to include 6 sequential steps. They begin with the red flags. If the red flags are yes, then remove from play for immediate medical assessment or transport to a hospital. If the red flags are no, then you go to take a look at positive, whether there are any positive observable signs. If it's yes, then remove. Glasgow Coma Scale less than 15, yes, remove. Neck pain, tenderness, yes. Spinal mobilization and cervical collar, remove. Coordination or ocular motor screen abnormalities, yes, remove. Memory and matics questions below 5, remove. And then you can begin with the SCAT6. So we wanted to front load this instrument with all of the important indicators that would suggest that something may be more severe than a concussion or mild traumatic brain injury. We also then worked to change the balance and postural stability component because we felt that it needed a better progression and more complexity. So we start with the MBES or the BESS. If the MBES or the BESS is good, in other words, there are no clinical findings on the BESS or the MBES, then you can go on to tandem gait and optionally to dual task tandem gait, which makes it even more complicated and more difficult. These are optional progressions. This is not a required part of the instrument. We also revised detailed instructions for all of those, and we are in the process of creating the comprehensive norms for development. So in addition to that, one of the things that I want to drive home and that is critically important is that the literature review revealed that there are marked differences in groups of individuals with respect to language, culture, education, age, race, ethnicity, and physical and sensory abilities. Because there are those differences, you can't use omnibus norms in order to interpret everybody's findings. So you need to be able to develop very detailed normative databases that are stratified by these variables where we know that there are differences in order to provide the best care. That takes time, that takes some effort, but once we get those, then it would really help us in providing much better care to these athletes because we have a better idea of what the comparison point is. Other thing that's important is that simple translations of the SCAT tools are inappropriate and they don't work. Don't do it. The reason for that is because in language, and some of these measures are based on language, words have different meanings in different cultures. They have different levels of complexity in different cultures and different levels of familiarity. So you can't expect that word, mouse, I'm making that up, translated into Czech or Mandarin is going to mean the same thing, have the same familiarity. Actually, it's probably going to be more in Mandarin because they use their zodiac calendar, or it's not the zodiac calendar, but it's a calendar based on animals, and mouses just happens to be one of them. So it's those kinds of things make an important difference when you're looking at individuals from different cultures. Modifications are necessary for para-athletes, both in terms of content and in terms of modes of administration. You can't just do the good old thing with everybody when they're different than you are. Even if you do a baseline, and if we get into that, then we'll go from there. Okay, I think that this is no longer working. Okay, SCOPE. So we talked about the SCAT being 0 to 6 days. The SCOPE overlapped that, going 0 to 30 days. The goal of the SCOPE was to have a multimodal, comprehensive clinical assessment in an office setting. So this is for those practitioners who are not experts in concussion, who don't see concussions on a day-to-day basis and want to know what to do with them when an individual is presenting to their office with a variety of different signs. So what it does, and it also can be used by the individuals who are expert in the area. What the SCOPE does is, or our thinking is, it hasn't been finalized, it may include symptom evaluation, neurologic screening, ocular motor functions, physical exam, including an examination of the autonomic nervous system, balance and postural stability, provocative physical exercise, sleep, and measures of psychological health and mental health. And what it does is you go through the SCOPE, you do the earlier parts, which are basically taking the SCAT and putting it on steroids. Then it helps you identify domains of functioning that may need help, and then further develop those by showing you instruments that you can use to further evaluate each of those. The other important part of the SCOPE and consideration for the SCOPE is to help those practitioners who are out there in the world dealing with concussions, like many of the athletic trainers who are watching this and are at the front lines of all of this and really moving it forward, what to do and how to do it using this tool. But it also provides you areas where it helps you identify when to refer. When this is something that is beyond your level of expertise, and when it's something that you need to refer out to someone with more experience than you have. With that, I'll say thank you, and instead of showing my Nittany lion, I'll show you a leopard that I met in South Africa on safari.
Ruben, on one of your slides, you showed the number of studies included in your systematic review over, I think it started in 2001 up to 2022. Did your group make any attempt to do a time analysis? I mean, so if we think about how concussion identification and management has changed over the last 2 decades, it's quite significant. But so if we're including all of these studies from 2 decades into kind of how we're going to apply it today, might have some bias there.
We haven't looked at that yet because that's outside the scope of the systematic review, but it's an important question that these articles can address. We actually looked at it from a symptoms standpoint, not over time, but over that 7-day span to see how it varied over, because even within that 7-day span, there's a lot of variability in there, but that's an excellent point and one that hopefully one of you guys will get involved with doing.
Dr. Echemendia, especially online, the SCOTE is generating a lot of interest. And question number 1, what does SCOTE stand for?
It is the Sport Concussion Office Assessment Tool.
Thank you very much. How long do you expect the SCOTE to take? Is it practical for use in the primary care setting?
It is practical to use that's part of what we're designing it for. How long it takes depends on how many modules you go into, right? It can take as little as 20 minutes, or it can take as much as an hour. This is not a 5-minute tool. You're not going to be able, I try to explain this to people all the time. You're dealing with the most complex organ in the body, and you want to test it in 3 minutes. That's just not going to happen. Not only that, but if you test it in 3 minutes, why don't you just ask them their symptoms? Right? Because that's all that you're going to get in 3 minutes. And then the symptoms don't help you differentiate between domains. So the push in primary care and in all healthcare is speed, right? Is to move it along. But it is and we discussed this a lot. We had a very firm stance that that's important. And it's important to take a look at the tool and see what areas are giving us more bang for the buck. But we're not going to cut it a priori just to make it a simpler tool, since we don't know how to cut. Once we know how to cut it, fine, we're happy to cut, but we don't know where to cut.
I have a question. You touched on this a little bit. You touched on it with the normative data that you're collecting. Had the group talk about the concept of baseline testing to be used with the SCAT6? Is that going to be a recommendation? Is it going to be a recommendation against?
Yes, we've had a lot of discussions on this. There are 2 schools of thought on the baseline testing. With respect to the SCAT, if the SCAT is going to be used acutely to help make the determination of whether a player is concussed or not concussed, to pull them out of play, you're standing on much safer ground if you have baseline information, particularly up to the point where you've developed a significant normative database where you don't have to do individual baselines anymore. So for example, my recommendation to you here would be, in this setting with these resources, that you baseline for 2 years. Once you baseline for 2 years, you develop your comprehensive norms, and then you can probably skip 2 or 3 years in between, because there are data to suggest that the aggregate accumulation of 2 or more baselines is almost as equivalent as the last baseline you took. So it's a better measure. The issue of baseline is also, it's always resource dependent, right? And I think it depends on what you're going to use it for. If the use is going to be to make a determination as to whether a player had a concussion, and you're going to put them back in based on that determination in the same game, I would want a lot more information than just a one-off baseline data with no normative data. If your decision then is, well, this guy was injured 3 days ago, 4 days ago, we've put him through his gradual exertion protocol, and he's looking, or she's looking pretty good, can we move forward? Then you can use the SCOPE, because now the SCOPE are giving you different options, and the data from the SCOPE lasts longer, or use other batteries that have been designed for that purpose. Does that? Yep. Thanks.
And could I ask you specifically about that? You described SCAT first, SCAT6 first, SCOPE for follow-up 3 to 30 days.
Or beyond.
Or beyond. And the number one item that you listed under the SCOPE was a symptom evaluation. Are those symptoms totally in lockstep with
Yes.
this? Oh, thank you. Those are over here too.
Yes. So you can set it up so that you've got your SCAT, and then you're starting to watch the symptoms over time clinically transition right to the SCOPE. A lot of the first part of the SCOPE you can compare then to the SCAT, and that will help you determine what modules you want to go into. For example, you may want to go into greater detail in ocular motor functioning and use the VOMs. For example, we didn't include the VOMs in the SCAT6. It's often a question we get because it takes time, right? And you don't want a 25-minute acute exam. So you can do a modified ocular motor exam and then do the VOMs later on in the day or the next day, either using the SCOPE or the SCAT.
Thank you. Maybe just one or two more.
Sure.
And one from online. You set this up by justifying the focus in the consensus and sport concussion group on sport concussion. Question from the audience online. Can the SCOPE apply for concussions that derive from a non-sport mechanism of injury?
Yes. Yes. So that is designed to examine the injury more broadly. So yes, that can go beyond sport concussion.
I have a question. And first, I want to say thank you as an athletic trainer for giving a tool that I can put in my fanny pack on the sideline for free that I've definitely used on the field. But my question is related to who is doing the eval, and have you thought in terms of overall SCAT development, other eval tools that are used in like an ED setting, and taking that or pushing the SCAT to be used in that setting versus just sport related?
So the SCAT can be used in any setting, and it's actually used in a lot of ERs at this point in time. The point is that we didn't do that for these reviews because that's a different normative data set. So what needs to happen is that the SCAT should be used in these other settings. And as we develop the normative data, then we can start figuring out how well does it work in that setting. I know a lot of ED docs who use the SCAT all the time. I know primary care docs who use the SCAT as well. So it just depends. The tool is agnostic to how the injury occurred, right? But it's designed specifically to pick up this injury in a sports setting, and that's where we get the norms from. But you can easily and importantly morph that into non-sports settings using the same principles. And we actually encourage that. And as to who would do it, you guys are going to be doing it.
Question here.
Yeah, so just quick question with the updates and changes that happen periodically. Are there any concerns or questions about how that may impact psychometrics with that? And I think that's a normal one that comes up, but like, can you kind of address that a little bit to any clinicians? Like, well, this has changed. How does this now affect that? Specifically, the kind of recall list or a good example.
So the recall measures haven't changed.
Or sorry, the going from the 5-word list to the 10-word list, for example.
You shouldn't have been using the 5-word list to begin with.
Yeah.
So I was being facetious, but you should not use the 5-word list. It is far too easy. Kids top out on the 5-word list. You should not use it. If we mess up the normative data for the 5-word list, all the better. At least from all of the data that I've seen, it should not be used. Perhaps in dementia, where you need a tool with less complexity. Remembering 5 words over 3 trials. Our athletes memorize them. It's yeah.
So that's
But
why-
with respect to the other normative data, we thought about that a lot. So we only made changes that we felt absolutely had to be made that wouldn't affect the normative data. And none of the changes we made, other than the 5-word list, would invalidate prior norms. Because, for example, the MBES remains, the tandem gait you can do on its own. If you want to keep those two, you can use the old norms. But the reality is that in the vast majority of cases, at least in North America, the SCAT is not used based on norms, it's used on baseline. The baseline post-injury comparison.
That's perfect. So the reason I ask is a lot of clinicians will have their baselines over the past 2 years, and if you're in this transition period between, want to make sure that the clinicians listening can feel some confidence that the tool they've already done a baseline on previously may have some utility going forward still.
Right, and when we develop regression-based norms, then we're going to be able to take into account all of that. And that's one of the benefits of having an electronic tool, because with regression-based norms, we can take all of those demographic variables, we can take all of those components into account, and it'll give you a probability table as to the extent to which these scores are related to a probability of a diagnosis of concussion. There's a lot. I mean, this is your bailiwick, so you guys can get to it.
Thanks again. Yeah, Dr. Echemendia, what a treat to have you here. You're an inspiration. Thank you for coming.
Oh,
Glad to have you at the Concussion Center, University of Michigan. And thanks to everyone for joining us online. Quick reminder that the Concussion Center, we're proud to host a special speaker series in just about 2 weeks. On the Friday, April 28th, we'll feature Ross Zafont from Harvard Medical School. A flyer will be sent out to email for subscribers next week. If you want to get information, go to concussion.umich.edu and sign up. So thank you again. Have a great day.